Good evening, everybody, and welcome to the classroom again. Okay, so today, as it has already been told that we are going to learn about VUR, and I think my view is that many of us are not practicing pediatric urology. However, as in PGI also, we see many patients of pediatric diseases found in the adults, like PUJ obstruction. Commonly, we are doing it. VUR, we commonly doing it. So those cases we are doing it, but not in the pediatric age group. This is a special age group, and this can be actually taught by people or the experts who are nationally as well as internationally famous, like Dr. Anil and Dr. Ganendra. I think they are marvelous and they are really experts. They are not going to. This is not going to be a symposium. So because they will add their own experience and expertise. So that's why it is going to be very fruitful. And I must thank and welcome all those delegates, or I mean, on virtual, or whether it is students or trainees, or the what our president says, the not only the young faculty members, even the old faculty members also see their commitment. And learning is a lifelong process. And I'm sure at the end of this discussion, all of us will be benefited, and it will be benefited to all of us who are even practicing pediatric urology diseases in the adult population also. And I wish you to participate actively. Participate actively means, I mean, participate in the discussion, ask questions, and share your experience also. Then only it is going to be fruitful. It should not be a monologue. It should be a dialogue, and it should be two-way traffic. And so I look forward to an engaging and fruitful discussions and webinar. Thank you very much. And I must thank
Thank you.
our principal Saiba also, Dr. Sujata, for doing this.
Next, actually, we in ISU, we have divided this responsibility among all the core members, and the topic, each one decides two topics, and they are means they will decide the speakers and the format of the webinar. Anyway, sir, so today's
From from
credit
from
goes to
from
Dr.
from USI, you are the principal. That's it.
Okay. So today's credit goes to Dr. Sharma, Ganendra Sharma. And it's my pleasure to introduce Dr. Anil Takvani formally. He's a practicing pediatric urologist in Ahmedabad for last 25 years and has many cases which he has treated. And he is a council member of the pediatric subsection, and also he is a part of our ISU core committee, and he is a faculty member in many of the pediatric topics at the zonal and national level. He has 3 chapters and 7 publications. So request you, sir, to please start your topic, and we'll definitely ask questions and participate. Thank you very much.
So I thank you very much, President Sir, Secretary Sir, and ISU Chair person for giving me this opportunity. And I agree with our Secretary Sir. Yesterday we had a similar miss on reflux. We had this webinar through the NB board, where Dr. Sabnis was uh, moderating the session, and I and Dr. Venkatesh Krishnamurthy he was putting the questions and we were answering. So it was just like a dialogue, and we'll try to see that we finish in time so we can get some questions and we can have some dialogue. So with that, with your permission, I'm sharing my screen. And once again, this topic overall is very close to my heart, and see that how much we justify. And thank you, Gyanendra, for giving me the first portion, and I will try my finish. So you can give me a reminder if I overshoot the time. So something I have to speak about the evolution of a child with the febrile UTI and reflux, which are what is the current concepts. So we all must know. See, for the residents, keeping residents in the mind, I have taken out the whole complexity and tried to make it very simpler. See, the urinary tract infection is the most common bacterial infection of pediatric age group. And at times, if it is neglected, it can lead to the kidney damage. And in a very few cases, that kidney damage can lead to the hypertension, subsequent renal failure, and the dialysis and transplant. And another thing which is very important is that the congenital anomalies associated with the febrile urinary tract infection. In 30% of the children with urinary tract anomalies, UTI can be the first sign. So the UTI brings that patient to us where we picked up the underlying congenital anomalies. And among that, the most common is the vesicoatric reflux. And failure to identify patients at risk can lead to the damage as we discussed. So how they present? Generally, they present with the high-grade temperature, which is of unknown origin, sometimes nausea, vomiting, sorry, excessive crying while passing urine, pain while passing urine, hematuria, frequent urination, vague abdominal pain, and failure to thrive. So it's very difficult to pick up. And for that, we need to categorize them in a high-risk patients. We'll discuss that. So I'm starting with the index case as residents are getting in the examinations that I'm providing you the 12 months female child, 3 times high-grade fever, amounting to hospitalization and IV antibiotics. But unfortunately, none of the time it was looked for the urinary tract infection or pyelonephritis. On 4th episodes, they picked up the febrile urinary tract infection, or you can say pyelonephritis. Culture was positive for E. coli, which is most common, and serum creatinine was normal. And patient, when came to me, was on AB prophylaxis. So next question will be that what will you ask in this patient in your exam? So you have to further ask the frequency of urination, constipation, suprabriefulness, whether the patient is having some retention of urine, spine-related problem. You have to also look at the spine, any dimpling, any focal neurological issues, sibling history, because VUR can be there in the siblings, which is 3 times common in compared to the normal one, and in the parents, as well as the history of antenatal sonography if mother is having some antenatal sonography, and any knowledge of hydronephrosis into that or any congenital anomaly into that. So this much we must need to ask. Now for this patient, what is next? Definitely next is the ultrasonography, because there are already 3 or 4 episodes of urine tract, pyrexias, where febrile UTI was missed probably. And here we have a high grade temperature. Again, patient is sick, so we have to investigate further. So after the confirming the diagnosis with the culture, the next is sonography. Here you can see it should be a sonography of kidney and the bladder. At the bladder level, you can see dilated ureters in the juxtavesical or posterior to the bladder in transverse plane. And here you can see dilated pelvic LSS system. And one can see also the so many things on the sonography. For example, we can see parenchyma, cortex, as well as the cortical ecogyricity. We can see cortical thickness, whether thinned out. There is some reduction or shrunken portion of the kidney, which is suggestive of pyelonephritis, like that, chronic pyelonephritis. So all these things we can see in a very well executed sonography. And once we have a sonography suggestive of hydronephrosis in a patient with a febrile UTI, which is infection has come under the control. Next investigation, of course, is the voiding cystolithography. And we all must know, all students should know the perfect grading, which is international reflux grading system. And here you can see that on right side, it is say grade 3. On the left side, there is a dilatation, a little bit of tortuosity, and the fornix is probably disappeared, but there is a papillary impressions are still there. So we can say grade 4. So all of you should know the international grading system. And then next comes the already having a 3-4 episodes of pyrexia, which were likely to be of febrile pyelonephritis. So DMSA scan to just look at the upper tract function as well as the condition of the parenchyma. So DMSA scan is the best scan for that. And we must describe the DMSA scan. See here, you can see that there is a no uptake with the loss of contour. Here also no uptake with the loss of contour. It is focal or peripheral on the polar region, very much suggestive of a scar. Rest this area having a less uptake. It's a photopenic area, but there is still no loss of contour. This is suggestive of acute pyelonephritis. So this patient has taken this kidney has taken the brunt of previous infections, which has converted into the scar. And right now, whatever the active infection which is going on, which is represented by this acute photopenic area without loss of contour. So we must be able to describe this, and we'll go in a little bit of detail. So the discussion is like that, as I discussed, and if time is there. We'll discuss something about the rationale behind the bottom-up and top-down approach and how to investigate BBD. Because bowel and bladder dysfunction is integral part of managing the urinary tract infection as well as the VUR. But many of the times we don't know how to recognize this underlying condition. So infant which is presenting with fever without focus, right? We have to see this patient doesn't come to us. So if you want to be a good pediatric urologist, we need to have at least one meeting in a year with the pediatrician surrounding to you. Means suppose if I was in the Junagadh, I was inviting all Junagadh district pediatricians and other pediatricians coming from other districts for a half-day meeting, and they need to discuss this thing, that you have a patient with a pyrexia of unknown origin, and there is a 2 or 3 days past. At least think about the presence of underlying urinary tract infection or pyelonephritis, because the incidence is of around 7% in neonates, in infants, and the 7.8% into the symptomatic toilet trained children. So think about febrile UTI. And what I started doing in an initial phase to convince them that one of the person was going there when this kind of a patient is there, and we were doing dipstick test. So dipstick tests are rapid test where we can get idea about the leukocyte estrus. If that is positive, it is suggest your presence of pus cells, or we can say WBC. And nitrite test, if it is positive, then it is suggest your presence of gram-negative organism, which is most common organisms responsible for the pyelonephritis. And with that, we insist them to do at least office microscopy. Few of the pediatricians picked up this, and if they see WBC, presence of WBC and the bacteria or WBC, then there is all the reason to believe that the pyrexia is because of pyelonephritis. And in that case, we have to go for a second step, that is collecting the sample. If this all tests are negative, means this nitrite is negative, leukocyte estrate is negative, there is an absence of WBC, there is an absence of bacteria, then there is a reason to believe that pyrexia is not because of pyelonephritis, which is hardly 1% chances that all this negative and still there can be a. So we can skip this second test, which can in a not much sick child, and we can avoid the catheterization by that way. And if there is all these tests are positive, then we start antibiotics after the collecting the sample for the culture, and it is a midstream clean catch for the toilet trained children, and catheter specimen for those who are not toilet trained, and it can be at times suprapubic aspiration if you are not comfortable in passing the catheter. So these are the ways to do it, and this is the exact definition that urine analysis showing pyuria. So there cannot be pyelonephritis. There cannot be culture positive, which is there because of pyelonephritis in absence of WBC in the urine or pus cells in the urine. So both the things are required to diagnose or to define the febrile urinary tract infection. A urine analysis showing the pyuria as well as a culture growing more than 50,000 colony-forming units per ml of a single strain should be the basis for diagnosis. If it is suprapubic, even the single, any number is considered significant. If it is bladder catheterization, then it is 1,000 to 10⁵, and in a midstream, it is 10⁴ to 10⁵, right? So this is the, we have defined the presence of febrile urinary tract infection or pyelonephritis. And these are the risk factors which we should discuss with the pediatricians, that any girl having age less than 12 months, temperature of 39 degrees centigrade, fever of more than 2 days, and absence of another source of infection. Similarly in boy, specifically uncircumcised boy, suppose if we take at 6 months, an uncircumcised boy having a pyrexia of unknown origin of more than 39 degrees centigrade, then chances of having a pyelonephritis of around 20 to 24%. In a circumcised child, that drops to significantly routinely at 6 to 7%. So this uncircumcised child, temperature more than 39 degrees centigrade, fever more than 24, again, pyrexia of unknown origin, these are the risk factors, and we should think about the underlying pyelonephritis. And it is very important to pick up this. We have to convey our pediatrician friend that delaying in the treatment, if the delay is more than 72 hours, then the chances that this pyelonephritis heals with the scar is very much high. And similarly, if we miss multiple time, or if we treat inadequately and there are recurrent episodes of pyelonephritis, then you can see that with the 4 or 5 recurrent pyelonephritis or febrile urinary tract infection, the chances of scarring is around 50% or more than 50%. So it's very important to pick up this entity in a patients with the pyrexia of unknown origin of a 2 to 3 days. And now coming to the underlying congenital anomalies, and this is without doubt, it is proved that chances of renal damage, which is converting in the scarring, is much more higher in presence of reflux in patients of febrile UTI. So febrile UTI doesn't require having a reflux, but if there is a patient with a febrile UTI having an underlying reflux, right, then there is a chances that this infection, which is very quickly to the kidney and lead to the inflammatory response, and which heals with the scarring. So we have to search for this entity with the other investigations, which we'll discuss. So what is the AAP guidelines? See, now the struggle is there whether to do VCUG in all these patients or not to do in all these patients. And we'll quickly discuss that. So what is the broader guidelines? That 7 to 10 days of antimicrobial, oral or parenteral. Once the infection is under control or during that time, we have to send the patients for USG, as we have seen. And the guidelines nowadays says that no VCUG after first febrile UTI, specifically in female child. And in male child, there is evidences on both the side. And VCUG only after the second UTI in the female. So these are the various societies, EAU, ESPU, AAP, ESPR, having a one thing is very common, that is to do sonography of kidney and the bladder and post-void residual. With that, few are believing in the top-down approach, few are believing in the bottom-up approach. So when to do VCUG and when not to do VCUG, when to do DMSA first. So we'll discuss this, right? So what is we follow, or we generally means, this is I have discussed with a couple of our friends, and that what we are trying, that our aim is to reduce also the VCUG. And for recurrent febrile UTI, for example, index case which I discussed, this requires undoubtedly VCUG, right? So those who are coming with the recurrent febrile UTI, VCUG is out of question. We have to do a VCUG without any doubt. But first in the female, or first in the male or second in the female, if it is age less than 1 year, all will go for a sonography. In most of those patients, even though sometimes sonography is normal, has to go for a voidic cystoscopy. And maybe DMSA if it is top down. We'll discuss this. Age 1 to 5 years, they are less prone for the renal injuries. Now, after the age of 1 to 2 years, so sonography, if it is normal, we can avoid at that time VCUG with the first or second infection, and we can start treating these patients, keeping in observation. And if there is a breakthrough infection or a new infection, then we can think about doing VCUG. And if age is 5 years, then the things are totally different. So what is the advantage of sonography? All of us are knowing that it is radiation free, it is available, and all guidelines, that's why it is recommending, right? It is very reasonable to include it into the all. And this is the how we can get the idea. Here you can see that hydronephrosis, you can say hydroureter into the juxtavesical area. Here again, you can trace ureter right up to the posterior to the bladder. You can see pyelonephritic changes also, and you can pick up some other anomalies like ureterocele or diverticulum or ureteric diverticulum, like sort of thing. You can see large number of things in the sonography. So sonography is the first investigation. What are the limitations of the sonography? That it carries sensitivity of 40% and specificity of 76% for VUR. It may pick up grade 4-5 reflux, but for less than grade 4-5, it fails to pick up. Approximately 25% of the reflux in kidney that are missed have a reflux of grade 3 or more, right? That means it cannot exclude clinically significant VUR, and even when the results are normal, and it is technique dependent. So we come on to the fluoroscopic VCUG. VCUG is the imaging test of the choice, or it is a gold standard test for the detection of the underlying reflux in patients of febrile urinary infection after the control of infection. It gives exact grade of UR, ureteral anatomy, delineates bladder outline, bladder neck, estimate bladder capacity, and also gives some idea about the ureteral anatomy. So this is the pictorial journey. You can see that this is the reflux. You can see the grade. You can see sometime intrarenal reflux. You can see the urethral anatomy. You can see the diverticulum. You can see the duplex system with the reflux. So all those things, you can have a proper grading. You can even see neurogenic bladder with the secondary reflux. You can see duplex system. Each and every detail, most of the time you get about the kidney, ureter, bladder, and urethra with the VCUG. That's why it's a gold standard when we are thinking about underlying VUR. So it's having a sensitivity of around 93%, specificity is almost 100%. VUR in patients of first febrile UTI proved to be a significant predictive factor for acute pyelonephritis and ultimate renal injury, as VUR predisposes for the recurrent UTI. So that's why it's important. So in summary, the relationship may not be one by one, one gym one means, but done VCUG done and picked up the VUR definitely helps in the awareness of us, treating doctors, as well as the parents, that what is undergoing. And that is how the over last 3-4 decades, the results of treating these patients of febrile UTI with underlying VUR improving, and less patients are ending up with the renal failures or hypertension and renal failures sequelae. So, but we must remember the VCUG is always with many times with the complications, painful micturition, hematuria, at times retention of urine, introduction of infection. And here you can see that this is a rare rupture if the bladder is filled beyond its capacity with force, not by the gravity. So when we send the patient, if we are not going with the patients and we are not doing on our own, at least we must know the bladder capacity of that particular neonate or infant or children. And we have to estimate that bladder capacity, and we have to write it down into the this requisition form, that this is the what I reside. I want this plate, lateral plate, and this is the estimated capacity. And if it is better to put an aseptic precautions feeding tube on our own, and then fix it, and then it's sent to the radiology shoot. And this is something about the radionuclide cystography, that advantage is highly sensitive. Even the single drop, if it is refluxing, it will pick up, right? So it is much more sensitive than the conventional VCUG. But problem is that it is less likely to give any anatomical detail of the ureter, exact grade of the ureter, as well as no much detail, anatomical detail of the bladder, as well as the urethra. So it's having limitations, but still it is having a much least radiation in compared to the conventional VCUG. So we must, if required, and if it is available, we must keep this in our armamentarium when we follow this patient for the status of the VUR, if you want to know over a time, post-operative, pre-operative, when we are waiting, when the patient's on antibiotic prophylaxis, and we want to repeat the, then it can be this, if it is available, it should be advised on in the place of conventional. And then comes the DMSA scan. It's the most accurate evaluation of the renal parenchyma, right? DMSA accumulates in the proximal tubular cells, and it stays there for long, provides excellent visualization of the renal cortex and the lesions. So what are these lesions? We can broadly divide in congenital and acquired. Now, congenital is something like that. You don't have a history of febrile UTI, and still you see a global reduction of the kidney, right? So this is the global change without urinary tract infection. These are the congenital lesions, and we must know, because that changed our treatment protocol and the prognostication. And acquired, as I discussed, it can be a photopenic area without loss of contour, which is representative of acute pyelonephritis. And there is a loss of contour here, you can see in the lower pole, as well as the here in upper pole. So if there is no uptake and loss of contour, that is only the time we must use terminology scar. Otherwise, it is a photopenic area without loss of contour, you can say. As well as here, you can see that this is a congenital or dysplastic or hypoplastic kidney, rather than using scar, because scar is always after the injury, like a infection which lead to the inflammatory injury, and then the healing. With that, we have a few other terminology. It can be a focal at one place, multifocal, multiple places in the periphery, generalized or global, as I discussed. New scar means in a previous DMSA scan, at that place there was no scar, but now the scar is seen. An increase in pre-existing scar means there is a 4% drop, 4% drop of the split function. And at that time, we can say that the pre-existing scar has worsened or increased. And then last comes is the severe damage to the kidney. This is a broad classification which was published in 2014, defining the congenital as well as acquired. This is the congenital one, and this is the acquired. There was never history of febrile UTI. Here the VCUG done to just understand the hydronephrosis. You can see the high grade reflux. The kidney looks like a boggy kidney, and there you can see hardly there is uptake. And these patients generally do not present with the febrile urinary infection. And this is the patients following the febrile urinary infection. So this is the broader classification regarding the IVU, CTIVU. Many times this question comes to me through the residents. It is relegated into the history. Why? The reason is that it is involved too much of radiations. It gives some idea about the upper tract functions, but now we have a very much good investigations available almost every center, and that is having a least amount of radiations and excellent informations of upper tract functions as well as the lesions or scars. So this is little bit of summary of radiation exposure. The one X-ray chest is having a 0.1 exposure, MSV, right? And then it is 10 days radiation from the atmosphere. DMSA having a lot of radiation in compared to the VCUG. But the difference between the DMSA and VCUG is that DMSA is the renal radiation mainly, and kidney is having a lot of you can say tolerance against the radiation. And in VCUG, the problem is that the radiation, though it is less than the DMSA, but it exposes the gonad, and repeated VCUG expose gonad too much. So this also we must know. And IVP and the CT-IVP involves 300 or 400 X-ray chest. You can imagine how much radiations we have given and how much of years. And then this is something like acute phase DMSA. Sometimes patient comes very sick and parents want to know what is going on in my child. And you are not in position to do VCUG. I at times do acute phase DMSA scan. At that time, I send the patient for DMSA. If I pick up the reason, then I have to believe that there is an underlying high-grade reflux. And after the patient settle down, I do VCUG and I get the high-grade reflux. So this is not just a one reason, but many people do acute phase DMSA scan because there is a very high possibility that you hit the significant VUR in those patients who come with the lesion in the DMSA scan. So that brings me to the two broader approach, that is bottom up and top down. What we are doing routinely, so not to confuse the resident, that what we are doing routinely that you speak, that is bottom up. We are starting from febrile UTI. We look at the sonography, kidney and the bladder. If you find something abnormal or patient comes again and again with the febrile UTI, then we do voiding cystoarthrography first. And then if we pick the high-grade reflux or some changes in the sonography, we want to know about the upper tract function as well as the parenchyma, we do the DMSA. So that is exactly all right. And that is what we have practiced and which is feasible. And but at times, certain centers, they do DMSA first in the patients where their demand is there. Or you want to avoid the catheterization of the child, then DMSA first. If the DMSA shows the lesion, then there is a reason to believe that there is an underlying high grade or clinically significant reflux is there. And then you do VCUG, that is the top-down approach. And this is the pros and cons of this. See, first go for our classical approach, that is bottom up. The advantage is that higher sensitivity and specificity. You are less likely to miss the reflux, that is specifically high-grade reflux. Lesser cost and easy availability. VCUG is available almost in all centers, even in the smaller center of India. The matter against it is that the VCUG is stressful study, as we discussed. It involves radiation and all those things. In addition, the most important, again, another thing is that it picks up the clinically insignificant disease at times, and which increase the burden of further investigations, unnecessary treatment, and mental torturing and harassment of the patients as well as the parents. So that's why this top-down approach has come. A negative DMSA precludes the need for the catheter, avoids VCUG in almost 50% of patients. And a positive study identifies the cohort that is most at risk or subsequent renal scarring. So if it is asked in the exam, there are these two most important aspects in favor of top down is that utilizing the top down, if you have that facility and if you are a believer of that, and the patient is having only 1 or 2 infections and the kidney is still looking good on sonography, right? Then you do DMSA scan. If there is no lesion, then you have to believe that there is no clinically significant VUR there, so you can avoid the VCUG. But if there is a lesion, you have to believe that there is a possibility of clinically significant or high grade or dilating reflux, and in that case, you have to go for a VCUG. So this is something about that. And very quickly, one slide or 2 slides that we discuss many of the time BBD. I get a question that how to investigate for BBD, how to get idea. So it is very important because UTI, VUR, and abnormal bladder function and bowel functions are associated with one another. And febrile UTI plus VUR outcomes are affected by the presence or absence of BBD. Whether you treat medically, whether you treat surgically or you endoscopically, it makes a lot of difference in the outcome. Swedish study for infants with high grade, which was conducted till 2017, broadly published in 2017 to 2019, which favors in these patients a bladder function was evaluated with the free voiding observation, FVO. It involves the number of voids. So child is kept 4 hours in the hospital and the number of voids are observed. Voided volume. Child voids in the diaper every time the diaper is taken away and the diaper is weighing of the diapers and done. So that is a voided volume, and post-void residual check every time with the sonography. Now in this 4 hours, whatever the sonography is done, the post-void residual has come. The mean of these PVR is done, and the weight of the diapers altogether becomes the volume or bladder capacity. And bladder capacity is equal to voided volume plus PVR, and capacity is considered as a 30 plus, normal capacity is 30 plus 2.5 into age in months. This is mainly for the infants, right? And PVR in a normal range is considered as a 15 to 20 in a less than 1 year child. So if there is any lower unit tract dysfunction, then it is defined as a 150 percentile of the expected bladder capacity and the combination of high residual urine. So see, urodynamic is not available most of the places. Urodynamic, very difficult to read in the presence of bilateral high-grade reflux, right? So this is the simplest way you get some idea about the bladder capacity, which is less. Because see, 2 type of bladder dysfunctions are noticed. One is either it is overactive bladder or it can be an underactive bladder later on. And with that, there can be a voiding dysfunction because of functional sphincter discoordination or dysynergia. With that, you have to see that digital stool chart and you have to show it to the mother or father who is taking care of this child and see that these 2 are almost normal, and rest other suggest these 2 suggest the constipated. So with this, we can get some idea about the BBD, and I'm finishing my talk on the evaluation of these patients with the febrile unit tract infection with the underlying VUR. Thank you very much.
Yeah. Sir, you have a few questions in the chat box. Would you like to take them right now or at end of Dr. Sharma's talk?
Yeah, let Gyanendra finish, and during that, I see the questions and we'll take it. Is that okay?
Yeah, it's fine. It's fine. So, thank you for your talk. It was very concise and it was very informative. Also, it was to the point, and I think we had to take very good take-home messages, especially about the approach to investigations, the need for investigations, and as you emphasize that we have to be in touch with the pediatricians in our area and make them also aware about the need for diagnosing an UTI and how it would help the child and prevent morbidity. So now I would like to introduce Dr. Gyanendra Sharma. He is a consultant urologist at Chitre Clinic, which is at Solapur. And in spite of being in private practice, he has a very academic mind. He's a member of our board of ISU, and he's also a member of the editorial committee of IJU, and he has a lot of academic interest, and he has published 30 articles. He demonstrates PCNL techniques very well, and he has a special interest in pediatric urology. I request Dr. Sharma to please start his presentation.
Good evening, everybody. First of all, I would like to thank President Sir, Dr. Lalicha Sir, our Secretary, Dr. Uttam Mite Sir, Sujata Ma'am, and Dr. Arun Chawla Sir for giving me an opportunity to be part of ISU and share my thoughts on medical management of reflux. Now, honestly speaking, it can be a very simple thing or it could be a very complicated thing because a lot of controversies exist in the medical management of reflux. Yeah. The basic aim of my talk would be why to give medical management or subject a patient to medical management in a case of primary ureteral reflux. Who are the candidates for it? What should we give? And importantly, how do we follow them up? Now, first, let us come to the core question, why medical management is needed for a primary vesico-ureteral reflux. And even an MBBS student would probably answer by saying that VUR causes damage to the kidneys. But is it so? What damages the kidney is not the reflux, but it is either the infection as proposed by the Big Bang theory, or it is a high pressure reflux where pressures go beyond 75 millimeters of mercury and cause damage to the kidney, which is a hammer theory. So in plain simple words, when we talk about the principles of medical management, there are two things. We prevent infection and we prevent high pressure reflux. What we need to understand is that prevention of infection is more important than resolution of reflux. So when we are talking about medical management, we are not talking about resolution of reflux by medical management. We are talking dominantly about prevention of UTI. So what is the aim of medical management? Obviously, it would be to prevent febrile UTI. And how do we prevent it? There are two ways. In a male, one of the best options would be to undertake circumcision. And in all, either a male or a female, it would be antibiotic prophylaxis. Now let us look at the evidence for the same. A recently published meta-analysis in Journal of Pediatric Urology in August 23 found that circumcised boys have a significantly reduced odds of developing any form of urinary tract infection. Now, what is continuous antibiotic prophylaxis? It is basically prescribing daily antibiotics at half to 1/4 of the regular therapeutic dose, preferably at bedtime. Now, two important trials which lend credence to the thought of giving antibiotic prophylaxis is one is the Swedish trial, which Dr. Anil Takvani alluded to, where they found that the incidence of recurrent UTI was higher in the surveillance group, that is as much as 57%, as compared to those on antibiotic prophylaxis, where it was only 19%. The other study, which has one of the largest study which was conducted, that is the randomized intervention for children with vesico-ureteral reflux, that is the REVER study, which incorporated 607 children. And when it was published in 2013, its conclusions were that continuous antibiotic prophylaxis reduces the risk of a recurrent UTI by nearly 50%. Children with bladder bowel dysfunction with reflux benefit by nearly 80%, and children who presented with febrile UTI benefited by reduction in UTI by nearly 60%. Another one of its conclusion was that the continuous antibiotic prophylaxis does not reduce the risk of renal scarring and its consequences. However, that was not the primary aim of this particular trial, and then there were a lot of reanalysis of this trial, due to which this particular statement should not be taken verbatim as which was mentioned in 2013. So few investigators have done reanalysis of the revert studies, and they found that the high-risk group will benefit from antibiotic prophylaxis. And they categorize the high-risk group as those who are, that is, uncircumcised males, those who are having bladder bowel dysfunction, or those who are having high-grade reflux. A subsequent reanalysis, which was published in 2023, showed that children who will benefit from antibiotic prophylaxis are those with bladder bowel dysfunction with any grade of reflux from 1 to 5, or grade 4 reflux regardless of the presence of bladder bowel dysfunction. Now, what it indicates that when we are talking about some patients benefiting with antibiotic prophylaxis and some not benefiting, which means that all patients of reflux are not at the same risk of developing infection. Which again brings us to the question, should we advise antibiotic prophylaxis as a blanket in all patients with reflux, or we should go for a selective risk-based approach? Now, why this aversion to giving antibiotic prophylaxis to all patients? Because there are some problems associated with it. Compliance, big problem even in the Western world, because only 75% of the patients in REVER study were compliant. Long-term antibiotic prophylaxis is associated with some complications like antibiotic resistance, development of childhood asthma, and also inflammatory or irritable bowel syndrome because of the altered bowel flora. And of course, cost is another factor. So let us first understand few important things again. First and foremost, VUR resolves spontaneously, especially if it is a low-grade reflux. The chances of resolution of reflux will be around 80% if it is grade 1 to 2, and about 30 to 50% if it is grade 3 to 5 reflux. Spontaneous resolution of reflux will be definitely facilitated if we correct the bladder or the bowel dysfunction. Also, we need to understand and imbibe it in our psyche that sterile reflux is unlikely to cause significant renal damage. Now, this is what has been reiterated in AAU guidelines of 2024 also. So now we are faced with two things. One is the risk of development of febrile UTI, and the second is the possibility of spontaneous resolution of the reflux. Now, in 2013, Hidas et al. Published their take on what are the risk factors. And they found that female gender, age less than 1 year, Caucasian race, bilateral reflux, especially if it is high grade and associated with bladder bowel dysfunction, and the primary presentation is in the form of scars or with multiple febrile UTIs, are high risk patients, where the chances of renal damage is more, breakthrough infection is more, and probably they would end up requiring surgical intervention more often. And they thus categorized the patients into low risk, intermediate risk, and high risk, and where they found that the incidence of breakthrough infection, even if the patient is on antibiotic prophylaxis, would be as high as up to 60% in the high risk category, which was defined as grade 4 or 5 reflux in a female who has dominantly presented with febrile UTI. And in 2015, they have also published a reflux risk calculator, where you can put in all these parameters and you get what is the risk of developing breakthrough UTI. And this is available on the net also. Now, we have often talked, Dr. Anil has also talked a lot about bladder bowel dysfunction, and I have also mentioned it as one of the risk factors. So what is the relation between reflux and BBD? It is very difficult to say. It is like saying what came first, the hen or the egg. Because reflux may be secondary to the bladder bowel dysfunction, and treatment of BBD will definitely help to correct reflux. This is proved. But at the same time, reflux may affect bladder dynamics, and this can also lead to bladder dysfunction. But what is proved beyond doubt is that reflux with lower urinary tract dysfunction will resolve faster once it is corrected. And at the same time, patients who are having lower urinary tract dysfunction are at a higher risk of developing infection and renal scarring. So the question is, how do we diagnose bladder dysfunction or BBD? Now, the classical teaching is BBD is diagnosed only in a toilet-trained child. Does it mean that we will not be able to pick up bladder dysfunction in a child below the age of 3 to 4 years? Of course, if we are cautious about certain things like whether the child is constipated, is having certain holding maneuvers, or there is increased residual urine on sonography, we would get a fair idea whether the child is having some bladder dysfunction or not. Of course, the Bristol stool chart is a very valuable tool to diagnose the degree of constipation. And I would like all residents to pay attention to the micturating cystourethrogram, because often we only look at the bladder contours and at the same time we are looking at only the diagnosis of reflux. But if we are able to pick up the fact that in a female, the urethra is dilated, mainly in the middle part, and is having a typical spinning top appearance, this is a very classical indication that voiding dysfunction is present. So if we look in plain simple words, as per the risk profile, we can decide whether antibiotic prophylaxis is needed or not. So those with low risk, by and large, antibiotic prophylaxis is not needed. So how do we categorize the indications of continuous antibiotic prophylaxis? And I am quoting it from the International Journal of Urology 2020, where they gave a very beautiful differentiation into children who are presenting from birth to completion of toilet training and are having reflux. So if the patient has presented without a febrile UTI, an antibiotic prophylaxis is needed only for grade 3 or more, but for grade 1 or 2, it is optional. Those patients who are presenting with febrile UTI, an antibiotic prophylaxis is recommended irrespective of the grade of reflux. Now, after completion of toilet training, again, they have categorized patients who are presenting in the form of febrile UTI and with or without BBD. Now, let us see each category. Patients without febrile UTI and bladder bowel dysfunction would be a very rare entity. If they are having bladder bowel dysfunction, antibiotic prophylaxis as such would be indicated. Now, those who are presenting without febrile UTI but with bladder bowel dysfunction, again, of course, the bladder dysfunction or the bowel dysfunction will have to be treated, but antibiotic prophylaxis is indicated in those with higher grades, that is from grade 3 to grade 4. Likewise, in patients with febrile UTI without BBD, antibiotic prophylaxis is needed for grade 3 and 4 and 5 till surgical intervention is planned, but is not required for the lower grades. And of course, if there is febrile UTI with bladder dysfunction, that's the worst combination, and antibiotic prophylaxis is recommended for all grades. Which means that if we look at all these studies, there are many factors which are brought into consideration, ranging from anatomical abnormalities, age, antibiotic resistance, renal scarring, presence of foreskin, of course, the genetic predisposition to infection. But two important things which are highlighted by every study is, one is presence of bladder bowel dysfunction or its absence, and an important aspect is looking at the characteristics of reflux. Now, what are these characteristics we need to consider? We often talk about the grade of reflux, but there are two more characteristics which are gaining more and more significance in recent studies. One is bladder volume at the onset of reflux, and second is the urethral diameter ratio. Now, why these factors are all important? Because they all give you an idea regarding the spontaneous resolution of reflux. Now, traditionally, we have been taught that the most important factor determining the spontaneous resolution of reflux is grade of reflux. But in the last decade, number of studies have challenged this particular concept. Now, this is something which all postgraduates know, that higher the grade of reflux, less is the chance of spontaneous resolution. In plain simple words, for grade 1, it is around 70 to 80%. For grade 5, it is around 30%. But the grading of reflux, we need to understand, focuses primarily on the dilatation of the pelvic ileal system. And the biggest problem is the lack of agreement in the interpretation of the intermediate grades, anything which is from grade 2 to 3 or 3 and 4. So for this, two indices have come up. One is the vesico-urethral reflux index and second is the urethral diameter ratio. Now, what is this VUR index? This was published by Kirsch et al. In 2014, where they brought a VUR index scoring system which ranges from 1 to 6. Now, it consists of four things: the gender, the VUR timing, which is very important, whether it was early reflux, that is before mid filling occurred, or after more than 50% of the bladder was filled, or nearly 75% were filled, or during voiding, the reflux was seen during voiding, presence or absence of ureteral anomalies, and the grade of reflux. And based on the VUR index, they proposed, or they found out that the resolution rate, if the VUR index was 1, was around 90%, but if the VUR index range went up to 5 to 6, then the resolution rate was only 11%. But again, we all know that very often the micturating cystourethograms are done by radiologists, where a fluoroscopic screening is not done, multiple films are not taken, and very often we get children who come with 1 or 2 films only. And here, one particular aspect which has been, in fact, first described in 1986, but has gained a lot of importance in the last decade, is the ureteral diameter ratio. What is it? It is the largest ureteral diameter within the false pelvis, which is measured in millimeters, divided by the distance from the bottom of L1 vertebral body to the top of the L3 vertebral body. These pictures depict this. You measure the largest ureteral diameter in the false pelvis, and then you measure the distance from the bottom of L1 to the top of L3. What Cooper et al. Found in 2015 was it correlates very well with the grade of reflux. But more importantly, they found out was that no child with a ureteral diameter ratio more than 0.45 had spontaneous resolution of reflux. And subsequent studies by Kirsch et al., who had published the vesico-ureteral reflux, and his group published in 2017 and 23, found that if the ureteral diameter ratio was more than 0.30, then the chances of spontaneous resolution of reflux are very less. So which index is better? We are looking at 3 indices: the grade of reflux, vesico-ureteral index, and the ureteral diameter ratio, and which of them predicts the resolution of reflux the best. And in 2020, Erlen AM, who belongs to the Kirsch group, who had come up with the vesico-ureteral reflux index, found that the VUR index and UDR, that is the ureteral diameter ratio, were superior to the grade of reflux to predict both spontaneous resolution of reflux and the risk of breakthrough UTI. A very significant study which got published in 2023 by Ekyal Ondar et al. Was that when they looked at the age of diagnosis, the presence of reflux unilaterally or bilaterally, the grade of reflux, the recurrence or multiple episodes of UTI, and presence or absence of BBD, against all these factors, they found that the ureteral diameter ratio had the highest odds ratio among the factors affecting scarring in reflux. And this is a very significant conclusion of this particular study. So in simple words, one can follow a very simple management tool, is that based on the presence or absence of bladder bowel dysfunction or the ureteral diameter ratio, we can categorize patients into low, intermediate, and high risk. Low risk patients are those with a ureteral diameter ratio of less than 0.3, circumcised males, and no BBD. Intermediate risk patients are those with a UDR of less than 0.3 but presence of bladder bowel dysfunction, or more than 0.3 without BBD. And high risk patients are those who have presented with infection and are having a ureteral diameter ratio of more than 0.3. This is a very simple tool which I often use in my clinical practice to categorize patients into low, intermediate, and high risk. And in these patients, we can decide, that is in intermediate category and high risk category, we can start continuous antibiotic prophylaxis. And the high risk category can even be thought of having early intervention in the form of a surgical correction. Now, few important things. Before starting antibiotic prophylaxis, confirm that there is no infection, especially once you have diagnosed reflux following your VCUG, confirm and ascertain that no infection is present. And of course, we all know that the common antibiotics that are used are amoxicillin, trimethoprim, cotrimoxazole, which unfortunately is not available so often at times, nitrofurantoin, and cephalexin. We need to remember that children younger than 2 months of age do not have good hepatic maturity, and hence amoxicillin and cephalexin are the preferred, and cotrimoxazole is preferred after the age of 2 months. How do we follow up patients on antibiotic prophylaxis? Urine routine should be done every month and whenever the child is sick. Ultrasound 6 monthly or yearly. A repeat VCUG is indicated after 1 year if there are good chances of resolution of reflux, and after 2 years if there are less chances of resolution. And the DMSA scan is usually advocated 2 yearly. Of course, during each visit, look for weight gain, blood pressure monitoring, and VCUG need not be repeated very often. It is needed only if change of management is contemplated. The next question which is often asked is, how long should we continue it? Minimum for 1 year after the last episode of febrile UTI, or in other words, we need to stop antibiotic prophylaxis at the completion of toilet training or after 2 years, even if toilet training has not yet been completed, or you have confirmed that there is spontaneous resolution of reflux, that is 1 week after a VCUG, and if there is a breakthrough UTI, because then antibiotic prophylaxis is not effective. Now, what are the reasons we come across patients with breakthrough UTI despite the fact that they are supposedly taking antibiotic prophylaxis? And the reasons for this are ABCD, that is antibiotic resistance, development or presence of bladder bowel dysfunction, problem with compliance because very often they have skipped medicines and they are averse to taking, or mothers are or parents are averse to giving medicines for a long period, and at times even the dosing is not correct. So what is the conclusion? The EAU guidelines mention that it may be difficult and risky to select patients who do not need antibiotic prophylaxis. So they advise manage all children presenting at the age of 1 to 5 years conservatively, or rather use antibiotic prophylaxis in most cases. Of course, these guidelines have not taken into consideration parameters like vesico-ureteral reflux and ureteral diameter ratio. We also need to understand one important thing, that the traditional approach of initial medical treatment after diagnosing and shifting to interventional treatment in case of breakthrough infections and new scar formation is not accepted by a lot of people, and the treatment should be tailored to different risk groups, and there is level of evidence to support this treatment statement is about 4. We need to also understand that surgical correction, if parents want it, would be a better option as compared to conservative management, and reimplantation or surgical correction for high grade reflux and endoscopic correction for low grade reflux is a very good way of approaching these things. So what are the indications for surgery in reflux? Now, if you look at the various editions of Campbell, probably these indications are not very clear in most of these editions. And I'm quoting these indications from what is followed by the Brazilian Urology Society, or has been published in 2020. That is, absolute indications for surgery would be urinary tract infection despite the child being on antibiotic prophylaxis, or a reflux with a very low chance of resolution and a very high chance of having risk of breakthrough infection or renal scarring. And relative indications would be persistence of grade 3 to 5 reflux in patients who are having renal scars, or who after 2 years of antibiotic prophylaxis still continue to have high grade reflux, because these are the patients who are at high risk of developing renal scarring and renal damage. But most important aspect in all these cases would be to rule out bladder and bowel dysfunction, which interestingly in my clinical practice is far more common than compared to what we actually learn as in our residency. So for sake of postgraduates, one simple slide to summarize the entire thing, and that's the last slide of my talk. a child is diagnosed with vesico-ureteral reflux, if he is below the age of 1 year, conservative management regardless of the grade of reflux. Above the age of 1 year, for low grade reflux, you may or may not give prophylaxis because the risk of renal damage in these patients is less. A simple tool to follow would be look at ureteral diameter ratio less than 0.3, don't give prophylaxis. Above 0.3, give prophylaxis. For higher grade of reflux, from grade 3 to 5, start with prophylaxis. If they ever develop breakthrough infection in the 2 years, go for surgical intervention. For lower grade, like grade 3, endoscopic intervention. For higher grades, definitely ureteric reimplantation. But if there is no UTI in the follow-up period, you look at development of new renal scars, presence and absence of bladder dysfunction, timing of reflux on VCUG if it is possible, or the simple tool of ureteral diameter ratio. If it is still more than 0.3, have a good session with the parents and see whether they are more compliant in follow-up or less likely to be compliant in follow-up, and offer surgical intervention as a definitive management. Thank you so much.
Yeah, thank you, Dr. Sharma. Actually, it was quite an extensive talk, and I think it will be available on YouTube for all the students who would like to go back and revise the points which were mentioned, because I'm sure at one point in time to take everything into your brain is difficult and remember it. Dr. Sharma, I'd like to ask you that there is a concept recently that pyelonephritis can occur in the absence of fever in children. So what is your view on it? So not
Madam,
necessarily for febrile UTI, the child can develop pyelonephritis even in the absence of fever. And then how do you exactly diagnose it?
Madam, I have also heard about it, but then I will have to probably read more about it, because how has somebody diagnosed pyelonephritis in the absence? Is it because of the presence of UTI and then subsequently DMSA scans? It is equally possible
So
that
it
very
may
often
be
this
possible that
pyelonephritis has been missed. The presence of
it
febrile
may be
UTI has been
diagnosed
missed.
maybe with regular.
See, can I give answer for this question? See,
Yes,
Sure,
the
sure,
Anil.
please.
problem with the pediatric or you can say neonatal or infant UTI is this only, that there is no specific presentation. Pyrexia of unknown origin is one of the presentation, but there can be not much pyrexia, nausea, vomiting, excess crying, then the failure to thrive, not catching up with the weight gain and all those things. We have to keep suspecting this also, that there can be a presence of very bad infection into the kidneys, and that suspicious works. So that is why, see, when it comes to the question of giving antibiotic prophylaxis or not, leaving on the parents that they pick up the urinary tract infection and they come and we don't give antibiotic prophylaxis in certain scenario, which is very much problematic in the sense that we even as a doctor or pediatricians repeatedly fail to recognize underlying pyelonephritis while treating. Then the parents with this a very good presentation, uh, it's very difficult to digest the patients who is proven with this pyelonephritis and the reflux not to be considered for the antibiotics. So this is a part, this is not opening another discussion, but the thing is that there should be a very serious kind of a suspicious, even in absence of fever. If we have other things which I mentioned, then we have to think about getting the urine checked for the infection.
So, in the absence of fever and this index child, you would advocate urine routine to be done every monthly, if I understood it right.
Not
And
every monthly, but if there is a child having a failure to thrive, vague discomfort, then the not catching up, nausea, vomiting, repeated sickness, and then excess crying, pulling the skin, and very frequent urination, all those things gives you relate a kind of indications that at least check the urine, and you may get some surprise into the urine and then subsequent other investigation. and
Yeah.
further.
There is nothing to tell them that regular urine routine micro should be done, or there is no recommendation of doing urine cultures
Madam,
regular.
I tell you, the problem with that, see, if the child go to the pediatricians, generally there is a lot of blood related investigations are there, right? Where the mind is not applied, whether it really they are indicated or not. But the urine is most of the time not done, at least in infant age. The reason may be that the child doesn't pass on our order, right? And they don't wait at the pediatrician hospital. They don't generally wait at lab. Even the urine is advised, they don't get it done. They come with this, urine is not passed. We have done other investigations. He checked, then prescribed antibiotic taken for 5-7 days. Fever subsided. They don't go for a follow-up, and that is how the recurrent episodes of febrile pyelonephritis taken place. And then in this particular era, even after this many of conferences and reading and advancements and the webinar and all those things, in a day in day out, I'm picking up the patients with the acute photophlonic or scar, where the urinary tract infection is missed or pyelonephritis missed in a good number of cases.
I mean,
Yeah.
And
simple words.
what I do
However,
whenever I leave this patient for the parents' discretion, then I always say that if there is a fever, I'm giving you 2-3 bottles, clean bottle. If you have a child get fever, and go to the pediatrician. Before you go to the hospital, collect this urine into this bottle and ask your pediatrician to check also this along with the other reports, because it's very difficult that time in a busy practice of the pediatricians and pathologists, they give some time. And so it is always important in this patient to give a couple of bottles to the parents, that if the child develop a fever or some other kind of a disorder, with disease, then at least get one urine check along with the other investigations.
Yeah, I think, sir, there are lots of questions in the chat box. In case they have not been addressed, I request both of you to take them first before I ask you new questions.
No, I have taken most of the questions, ma'am.
Okay.
Mainly were related to the
Anybody
top
in
down
the
and all those
audience
things.
would like to ask questions? Please go ahead.
I have few questions for Dr. Anil and Dr. Gyanendra.
Yes, sir.
Can I
Please
go
go
ahead?
ahead. Yeah, of course.
Anil, my question is, supposing you have a child where you're suspecting fever based on the recurrent febrile UTI. Let us take a young child, the 1 year, 2 year, and you do MCU, and the MCU is coming negative. DMSA is negative. So what do you do? Your suspicion is very high. Child is having recurrent febrile UTI. I'll give you the option how the practical dilemma comes.
Yes, sir.
You repeat MCU after some time. Sir,
I believe I and most of us are believe that all urine tract infection don't require reflux. And all reflux doesn't cause the urine tract infection. We all know now. So even if in this particular setup, you say that still after giving a lot of consideration, truly speaking, in my practice, 25 or 30% of time I don't pick up the VUR, right? And I have a best available sonologist like Gyanendra. And if there is no much changes seen on the sonography in the cortex or parenchyma, I don't push this patient for the DMSA. Now, in these circumstances, I do believe that probably I have missed other things like prepusal hygiene, renal hygiene, constipation, fluid intake, or frequent voiding in little elder child. So all these things we have to rectify along with the a long duration of culture sensitive based therapeutic course with the little longer prophylaxis, and in most of the cases this works. But I don't push this patient for cystoscopy or cystoscopic related identification of a rare kind of a reflux and all those things. I don't think.
Yeah, and the second question is, you mentioned about circumcision. Okay, and I'll just get back to 2022 seminar, again a webinar in ISU with you and Ansari. We were debating whether circumcision should be done or not. We know that you need to have some 100+ circumcision to prevent UTI. And you quoted one recent evidence that circumcision is beneficial for preventing UTI. Am I right?
Yes, sir.
So now the question here is, under what age group this circumcision will be useful? Below 1 year, 1 to 5 year, or more than 5 year? What is in your practice? What do you follow?
Sir, in my practice, what I follow is that up to 5 years, if they have presented with UTI, I definitely would ask them to go for a circumcision. Now, after 5 years, my take is whether they are able to maintain a good preputial hygiene or not. It depends on a lot, depends on that. Because after the age of 5 years, very often children will not allow their parents to uh, give them a bath and other things. So based on that, and it depends upon how smart the child is, how bad the preputial hygiene or how good it is when he has presented to me, that has an important bearing. But
So
if he is having, yeah.
I give you a little another way. I absolutely agree with the Gyanendra that your question is also very interesting question, very nice question. That suppose if I have a child, 6 months, I diagnose febrile unitary infection, underlying VUR, right? I'm putting the patient obviously on antibiotic and antibiotic prophylaxis at this age. I don't like to operate. Definitely, I will do circumcision without fail. After the year of 1.5 or 2 years, when patient comes and the prepuce is very much retractable, and if I see that there is a good prepusal hygiene is there, then I discuss these two options with the parents, that either you continue keep good hygiene, care of the prepusal area, or if you cannot, then we go for a circumcision. Because in either of the case, a good care as well as circumcision, which give both gives a good it gives a help in preventing the further episodes of the febrile UTI. But till the skin is not retractable, it is not advisable to forceful retract it or using something which open up the skin and wait for that. But if I'm putting that at that particular age, till 1.5 year, I'm putting the patient on antibiotic prophylaxis regime, I definitely go for a circumcision. And it definitely reduces it significantly, not reduces, but significantly reduces, and the literature evidences are there, though it is on either side, both the side, but still in our practice we see. I absolutely agree with the Gyanendra in that case.
One more question. A child is below 1 year, not thriving on antibiotics season. He or she is on injectable antibiotics. And she shows a high grade unilaterally. So what you have two choices, whether you will in practice you put catheter for some time with some antimuscarinics, or your take on vesicostomy in this child.
Sir, psychostomy is a very rare necessity in the management of reflux. Yes, it has been done occasionally when there is bilateral high-grade reflux and the child is very bad. He has had multiple courses of antibiotics, becomes okay for a very short period, and again has evidence of UTI. So in that scenario, sometimes yes, our psychostomy is needed, but otherwise, most often, uh, good cover of antibiotic, which is properly based on a good culture done. And I am emphasizing on these words because I still believe that in majority of the tier 2 or tier 3 cities and taluka places, getting a good culture is a very difficult thing, very difficult thing. And if proper culture specific antibiotics are given, if need be, catheterization for a short period of time, and taking care of associated factors like constipation and other things, more often than not, we are able to manage an episode of severe UTI. So, need for vesicostomy, I personally feel would be yes, theoretically, yes, but practically, very less needed.
So,
Anil, you have more experience in this.
Chawla sir,
Yeah.
I would like to answer you this question because the reason that in my 25 years of practice, I do get a patient come detected at 6 months, once again 6 months, 8 months, having a severe constipation history, male patient, circumcision, antibiotic prophylaxis, trying to treat constipation. They are coming from the low socioeconomic class, and they don't they come because of one or another reason, because not treated properly constipation, not taken care of oral other things, and if there are breakthrough infections. I'm not going to do reimplantation, bilateral tapering reimplantation or bilateral implantation for grade 4, 5 in a less than 1.5 year child because of two reasons. One is I don't have a bladder capacity, enough capacity to make a good tunnels. And second thing, I don't believe that that bladder is not playing any role because that bladder is likely to have a hypercontractility or overactivity. And in that case, I have done a couple of vasostomy, and that has worked extremely well in favor of the patients. Their hospitalization because of breakthrough infections, IV antibiotics, hospitalization, all this disappears, and they start growing. The parents are feeling that 1 year finished, but still we don't want to go ahead with this reimplant and closure of the vasostomy. We still want to continue. Another benefit it gives, sometime in a very dilated ureter, the ureter also significantly reduces in the dilatation, and we can avoid even tapering, and simple reimplantation becomes sufficient. And third thing, initial my days, I was believing that vasostomy bladder, it will be very difficult to operate or to taper, but that is not the reality. It is little bit of anterior radiations most of the time. Otherwise, the field is virgin, and you can do the equally good reimplantation procedure. Sir.
Yeah, one final question. A child being followed up with antibiotic prophylaxis, say high-grade VUR bilateral. So the child has developed a secondary PUG obstruction. It's a king to ureter. So how do you diagnose obstruction in these patients who are having VUR, and how do you manage it?
Yes, sir. Good question. The usual diagnosis is based on a good micturating cystourethrogram, where you find that the PUJ has not drained even in the post-void films or the later films, or the contrast is quite has become quite diluted. So the most important thing is to have a high index of suspicion that there is an associated PUJ with reflux. Now there are two things. It could be primary PUJ with associated reflux or reflux causing secondary PUJ. These are both the things. Now, if we have diagnosed that there is a PUJ obstruction along with reflux and a surgical correction is needed, of course, PUJ takes precedence because that is more likely to damage. So PUJ pyeloplasty is done first, and if need, reimplantation is done later, and both are never done at the same time because you are disconnecting the ureter at both the ends is inviting trouble in the form of stricture. So this is how I approach these patients.
So the thing is that I absolutely agree with the Gyanendra. When we have a strong suspicious, and when we subject this patient for the trend is not to do DMSA scan in these circumstances. When you are suspecting an obstructing refluxing this megaureter, or you are suspecting UPJ along with the primary VUR, putting the feeding tube into the bladder as a continuous drainage, and you can go for a MEG3 scan. Which will give you equal information about the renal function, as well as good information, relatively good information about the parenchyma also, and also the information regarding the drainage at the UPJ. When the catheter is there into the bladder throughout the study, it will definitely get the VUR. And one scan, there is no need to do DMSA for VUR and another diuretic scan with the catheter for the suspected UPJ or VUJ. Single scan is more than sufficient. There was a good debate in ESPU, the last ESPU on this. The pendulum is swinging towards the MEG3 scan, even as a routine scan in a reflux patient, for two reasons. That MEG3 is giving equal good information about the parenchyma and having a half of the radiation in compared to the DMSA. As this question is asked in the chat box, I was also always surprised that the MCU is having a probably more radiation in compared to the DMSA, but the DMSA is the only radioisotope which stays very long into the renal parenchyma, and it gives a good amount of radiation to the kidney and surrounding area. But kidney is very much resilient, right? And the radiation dose is higher than this well-tempered VCUG, which is a fluoroscopy, pulse fluoroscopy guided with a minimum plate it is having a 0.1 to say 0.6 or 7, this milli something its dose is there. In compared to that, the DMSA is having a 10. And the MEC3 and as well as DTP or EC is having a half than that, that is 0.5. And 0.1 means 1 X-ray chest. And that is of 10 days natural radiation which we receive from the atmosphere. And the DMSA is having a radiation dose of 10, which is equal to the 100 days of natural radiation which we are receiving from the atmosphere. So once done, yeah, with the catheter inside can be sufficient to rule. And once there is a UPGO, if you prove it both the primary, definitely the pyeloplasty first. And sometimes it helps in also the proper urinary flow from the kidney helps also in the growth of the ureter at the lower end. And with the increase in age of the child, the chances of spontaneous resolution is increased once we treat the UPGO first.
Thanks, Ganendra. Thanks, Anil.
So, sir, we can come to the conclusion of this webinar because it's almost 10 p.m. And I thank both Dr. Ganendra Sharma and Dr. Anil Takvani for giving us this really detailed webinar on VUR, and it was very informative, and it will be available on YouTube, so it is there for you to revise whenever you need it before exams. So thank you very much. I thank our president and secretary for attending this webinar, and Dr. Chawla sir and all other senior and junior members. Thank you for your presence and active participation. Thanks, Prashant. Thank you, everyone, and good night.
Thank you, ma'am. Thank you.
Thank you.
Thank you. Good night and bye.
Bye.
Good night. Thank you, sir. Bye.